We got wisdom from MUSC, WellSpan, Baylor, Scott and White, and Providence. You should advertise that because I think they'll every health tech vendor will probably watch.
Well, I think that's like the beauty of it all, right? Is that like health systems sharing, right, and collaborating and what's working. Okay, what's going well at Baylor? What's going well at I think that's also what a lot of vendors don't realize is
talk.
Yeah, we talk
a lot.
Is this unusual, your relationship that you guys have? Is this unusual? Or everybody has these kind of soft networks like, what do you think about XYZ telehealth company?
Yeah. And I was pleasantly surprised when I got more into a leadership role, how eager everyone was to chat. We all have the same problems.
Yeah.
And so nobody's hiding their cards, but we do talk. It's actually how Evie and I met and fell in love over a Zoom call about RPM because I was like, hey, what's Providence feel about this vendor? It helps. And I think it goes to Caitlin's co-development. If you're not a co-developer, then the other health systems are going to hear about it.
Welcome to Beyond the Blueprint. My name is Greg Malkery. I'm the Managing Director at Lighthouse Health Tech Advisors. And today we're asking a simple question. Why do so many hospital pilots stall? And what does it take to turn a good idea into lasting performance? This episode is part of our collaboration with AMDIS, the Association of Medical Directors of Information Systems. To help us unpack this, I've invited 3 healthcare leaders who've done what most hospitals can't. They've turned pilots into lasting transformation. So who do we have with us today? Well, we have Dr. Evie Cunningham, Chief Medical Officer at Cadence and the former head of virtual care at Providence Health. We have Torrence, a Senior Director of Innovation at WellSpan and also the former Executive Director of Health Solutions at the Medical University of South Carolina. And we have Dr. Camille Bradley, VP of Patient Experience and the Medical Director of Virtual Health Services at Baylor, Scott and White. So together, we're going to explore what separates pilots that fade from innovations that can help transform care. With that, why don't we go beyond the blueprint? Healthcare doesn't have an innovation problem, it has a pilot problem. Hospitals launch thousands of pilots every year, but fewer than 20% of them ever scale system-wide. According to a recent AMA survey, 6 in 10 physicians say that digital tools make their life harder, not easier. And this is what we call the pilot graveyard, where good ideas waste time, they drain money, and they burn out staff. But some pilots actually break through, and I want to tell you about a few of them now. At Providence Health, virtual care scaled to 1.2 million visits across 50 hospitals, supporting 10,000 providers. At the Medical University of South Carolina, a statewide telehealth network now connects 80 hospitals and hundreds of clinics, redefining rural care access. And at Baylor, Scott and White, digital care now spans more than 1,000 clinics statewide, connecting providers and patients across Texas, making virtual visits a seamless part of everyday care.
Now, before we dive into today's discussion, I want to recognize our valued sponsors who've made Beyond the Blueprint possible, Simplify Medical. With their support, we're able to bring you insightful conversations around healthcare design and innovation. If you enjoyed today's show, I encourage you to subscribe so you never miss a future episode.
So with that, why don't we get started? Well, we've all seen it. Pilots start with a strong amount of energy, then they fade away before they ever get a chance to grow and scale. Evie, I'm going to direct this first question to you. You've seen more pilots than most. When a hospital says it's running a pilot, what does that look like in practice?
Right now, really kind of depends on the health system that you're in as far as like what the meaning of pilot truly is. But I actually think pilot is sort of a bad word nowadays. It really kind of actually creates a little bit of like angst and sort of frustration to frontline clinicians because so many of these pilots have failed. I actually think that the name pilot needs like a rebrand and a refresh. When I think about pilots nowadays, especially since so many of them go to the graveyard, I actually think of pilots as experiments. And when you're actually going to run a pilot, a true pilot, I would be viewing that more from a research perspective, an innovation, let's test something out perspective. I think we need to really start thinking about pilots as experiments and like tests of change and just, hey, validation that this is a thing. And then when we're actually thinking about an innovation that we want to bring to scale, a transformative program, we should be thinking in phases, really. And what's that phase one deployment? And then what does this look like at scale? And what types of investments are we going to make in integrations and change management and all the things that need to happen in order to get it to scale? I would actually bucket pilot more as like something that we're not really sure it's going to scale. We're just going to test it out. And then phased deployments as more of like how you would view something that you're going to actually bring across the institution and invest a lot in deploying.
Wow, great
I see
point,
Caitlin
Eddie.
shaking her head. So
Yes, totally agree.
Camille, just to get you into the discussion here, once the excitement fades, how do you decide which projects? I'm never going to use the term pilot again. Which projects deserve more time and which ones are just draining resources?
I think when it comes to pilots, it almost implies that you're testing out a process. And if you're that far down where you're on a front line and you haven't considered the process yet, it's dead on the water. You kind of have to start with the process, be very clear on what you're changing and what your hypothesis is. I love the experiment analogy. Because you also got to be ready to do the iterative process. So your hypothesis is confirmed or denied, and you adjust accordingly, and you go from there. And there's some technical components. And so we always have a couple people where we will turn it on, because what goes on in test and what goes on in prod can be two different things. And we've got friendly folks that can help us with that. But then after that, hopefully we've considered what a provider or a patient is expecting from that process already. And it integrates better. One of the biggest contributors to physician burnout that you mentioned is what I call digital tools done poorly. So trying to figure out how to integrate that as opposed to just get that square peg in a round hole makes a big difference. I think the other thing we've done really well is what I call my collective group of entrepreneurial weirdo providers that are just intellectually curious about making this better. And they're okay if it doesn't work day one, and are good at the feedback. And they're a bit of a unicorn, but they exist in every organization. And finding those folks, having them pressure test almost initially, but what is working, what isn't. And then it naturally gets to a point where we reach a critical mass of this is going to work. And then we just flip the switch. Now we know it's in the process. The technical bits are worked out. This is going to help. Then it's a change management effort to explain to 7,000 providers that it's going to be okay to try something new.
Great.
But if you get your group of weirdos who want to try this out at the beginning, it helps a lot with that process as well, because my providers trust that we've done this with real live action patient care.
Early adopters are key. I remember the early Apple commercial, right? The weird, which is fine. Caitlin, I want to get you in here because I know you've done this successfully across different organizations. What are your thoughts on this topic?
Well, I think just to add to what Camille and Evie both shared, I think having, those clinical champions instead of weirdos, I call them clinical champions.
That's probably better.
Engaged.
It is what it is.
Early. And I think even taking the step back, even before the process piece, really starting with the problem. What is the problem that we are trying to solve, and really understanding that problem? Something that I'm really fortunate to have at WellSpan, and that we've made the investment in user design researchers and folks that can really come in early on before we ever start an initiative, really dig into the problem, start to map out the process pieces as Camille shared, and then we can bring in the solution. And so I think having that people and process ahead of technology is incredibly important for finding success in a initiative, or even launching phase one of an initiative instead of a pilot. I mean, I think that really helps you in scaling, because if you start with the problem, you immediately start to know what to test, right? Part of building out your ROI analysis in phases 1 and beyond really often is measuring the things that really matter and moving the needle for the organization. And oftentimes I've seen when the pilots didn't scale, it's because there weren't the metrics that you needed. You didn't actually know what metrics you needed to measure. and you didn't have the right folks engaged from a leadership level all the way to an end user perspective. And so having all of those levels of engagement as well as the measurements really, I think, is important in scaling.
That's why pilots are often experiments.
Yeah.
Because they don't have the institutional support that they need often.
I think this is a great point. Even if your project, I wasn't going to say pilot, even if your project's well-defined on paper, the real challenge is how do you get physicians and nurses to use the tools on a daily basis on the front line? And that's what we're going to get into now. So Camille, don't get too comfortable. So you've seen this up close. How do you turn clinician frustration with technology into actual genuine engagement at scale?
It involves being crystal clear on what you're trying to solve for them. And especially when you kind of think back to the first big technology interaction for a physician was our EMR implementation. And there was a lot of harm done in that process. It went very quickly. It disrupted a lot of processes. We got there, and I think the benefits outweighed the problems of getting where it needed to be. But there's a distrust of somebody coming with something techie and it actually helping things. There are a couple of ways that it's the same thing with they need to trust the person who's validating the process. And I think that's where the weirdo champions come in. The second piece is being kind of showing your cards of this was what I came to solve for. Here's why I think this would have worked. Here were my metrics, my data. They're scientists at the end of the day too, that shows that this is going to work for you. And can you trust me to try it? If you pick the right problem, they'll be ready to try it no matter what. I think my favorite implementation we've done in the last year was an ambient listening scribe. So an AI, basically assistant to write your notes. And we couldn't keep up. As soon as somebody saw someone else using it and how A, easy it was to use, and B, the problem that it solved, they were, beating down our door to use it.
Yeah.
And it's because it so elegantly addressed a huge problem that adoption wasn't an issue.
Yeah.
This is a great point. We had another speaker who I know Evie knows well, Jessica Schlicker, came in and talked to us about MedPearl. It seemed like that was the exact opposite problem. The doctors couldn't wait to get their hands on it.
Yeah.
So Evie, your team obviously did something incredible in creating momentum almost on a viral level. But maybe you can talk a little bit about
I mean, it was a lot of socialization, a lot of, Caitlin, you were part of that, I think, movement in the very beginning. And Camille, you and I talked many times over the years, but clinical decision support is obviously now a really big thing. Everybody's talking about it. But 3-4 years ago, it wasn't as top of mind. And we did a lot of going out, socializing, helping people understand what the problem is, getting feedback from the clinicians on the front lines. We had our group of weirdos, Camille, that tested out the first beta version of this bot that I built myself initially, and then validated that this is a real thing. If we can do really listening to the frontline clinicians to say, well, if it doesn't quite fit into my workflow, or if you could add this, and this, it would be even more compelling. So really kind of taking the time to learn from the front lines and listen to their feedback when they feel like they're heard, and then they're influencing the product and the design and the workflow based on the feedback they're getting. That's how you start to get more and more buy-in. And docs need to sell to docs. Providers need to sell to providers, evangelizing a tool and saying, hey, this is really helpful and helping me, just like Ambient, your Ambient story, Camille. The reason why it spread like wildfire is because we started talking amongst each other about how helpful the technology and the solution could be. And I'm at Cadence now, so I'm on the other side of trying to go through the process of how do we bring Cadence in, get the docs excited, start to phase things out. And it really is, the same types of principles. You got to give the clinicians the time that they need, the change management time, the resourcing for that change management, explain the problem really well, help them understand it, and most of the time, if it's a problem that resonates with them, they're going to sign up and give it a try, and then really give them the support that they need for that implementation process and do it in a very methodical way. And, it's the first time you're trying to do this, especially as a health tech company that's kind of getting into the space, it's a little bit clunky in the first couple implementations. But as you continue to scale and grow, you kind of get it down to like a science. Like these ambient scribe companies, for example, have really kind of gotten it down to like a rinse and repeat science of how they do that. We're learning the same. We're going through now, we have 20 health systems that we've deployed at. So we're learning a lot of the same principles that we can then bring and apply to different health systems as well, so that we have these successful deployments.
Wow, that's great. Caitlin, what are your thoughts about getting clinicians involved early on?
Yeah, I mean, I think I have a unique perspective on this as the non-clinician on this call, right? But I think it's so important to have your operators really closely partnered up with your clinical team. So I always, as I mentioned, the clinical champion piece, there's also a really strong need for having an operational champion and having someone that they might not be the end user that often, right? I rolled out Ambient while I was at MUSC. I was not a provider, but I would say it was very valuable to have someone in my role to help navigate the organization, help to partner up with our clinical leadership to really bring the pilot to life and then to also help them scale it, right? I think our clinical leaders are so valuable for everything that Evie and Camille have both mentioned, right? How do you have providers talking to providers, and how do you have them really resonating on that process and that the use case and the problem to be solved? But there's a lot of components of these initiatives that having that operational stakeholder partnered up that is really, really important. And so I see it as a really close partnership. I think the best programs that have scaled beyond just that initial experiment or pilot have had a really strong partnership, have had a strong leadership on both sides to take it across the finish line and help scale. So that's what I see as being super important. And I echo everything that the others have shared around how do you communicate? There's no such thing as too much communication.
Mhm.
And so getting in those right forums, having the right people present at the right places. And I think that's where you find success.
I think
Awesome.
operators can be a great place to start, either right before you're going to try something or right before you're going to scale. They have a front row seat to all of the workflows. And if you've solved for the majority, the operators are going to be able to see that. If you haven't, they're going to be able to tell you real fast that that is just going to take a lot more effort to implement, because they can tell it's not going to go over well or the messaging isn't right. They're the ones, they're the messenger that is getting potentially killed along the way whenever those things come down. So they know exactly what sort of messaging, or have you missed the mark on what a process would look like at scale before you ever even get into the providers.
Well, and they also often can assist in the accountability piece, right?
Mhm.
So oftentimes, especially in my role, I'm involved early on, but not for the long haul, right? And so you've got to have someone really engaged, even in the Ambient example, that is checking in with the providers. Oh, things aren't going well. Let's get you plugged in with customer support, or let's get your answers. And that's so important for a change management perspective and really in helping scale, right? Not treating it as a pilot. If we're treating this as a long-term initiative ingrained in the workflows, you need long-term owners.
Sounds like you need to have the right infrastructure in place, right? So at least what I read in the media, every health system loves the idea of an innovation lab, right? But are innovation labs engines for change, or are they just expensive showrooms, right? So is the innovation lab tied in with informatics, right? Where you're actually going to deploy this at scale? And what are your thoughts on this? I know, Evie, I know some of the health systems you've been involved with have had Are innovation labs a good thing, or are there ways in which they could be better integrated into the process?
Yeah, I mean, I think it kind of depends on how you structure it. And I've actually I've admired from afar some of the things that they've done at MUSC and WellSpan when I talked to Caitlin, and kind of how they've sort of structured some of their approach. It's really interesting and different. And in academic centers, I would say innovation labs are really spaces for experiments, for research, to validate hypotheses, to test things out. At Providence, we had We had a lab where we would like set up like hospital room of the future and like test out different technologies. If we were going to deploy, for example, virtual nursing, we had like almost like a hospital room lab, and we would, test the workflows in there, test the different tech solutions. And then that would be a place where then we could bring it to an actual site where we would test it out. So I think in that sense, I think that those types of resources within health systems are very helpful and can help with test of change before you actually bring things forward. But I think long-term strategy wise, health systems do not have a core competency in like building products like hardware and software products for commercial grade scale. Like that's not like what most health systems like do well. We need partnerships. So we need innovative partnerships where we can work together with health tech companies that are well resourced, backed and funded to help build the next generation of digital and hardware and technology solutions that can be brought into health systems. And health systems have a lot to gain in structuring these partnerships in the right way that brings value add to them, that lets them influence the product roadmap and delivery of these solutions, but then also have the opportunity to make sure they make good choices and selections on who they want to partner with so that execution happens on the partnership side.
Actually, that's a great point. So it sounds like you may have an innovation lab, but is there also an innovation arm within informatics that was responsible for the EHR and other types of technologies? And are they communicating and collaborating with each other in an effective manner?
I mean, there's always opportunities for improvement on those things. I think I've seen, depending on the size of the organization and the complexity of the structure and the way that things are structured, but I do think that historically, informatics had been more focused around the EHR. And I think that informaticists and CMIOs have realized that there's this broader ecosystem. Yes, the EMR is going to be the, central point for a lot of the things that they're going to do. There's abilities to actually internally innovate upon the EMR with different tools that are available from the EMR vendors, but they're not going to be able to completely solve everything with the EMR. And there's a broader ecosystem. And I think more and more innovation and the connection of innovation to informatics is happening, especially with like these chief AI officers or AI innovation folks. So I think health systems are figuring out what the best blend of structure can be. But yes, I do believe that those two should be more and more tightly aligned and integrated.
Camille, what are your thoughts? Obviously, you represent one of the top 10 health systems in the country, and they're doing some great stuff. What's your take on this topic? And I think it might be very insightful.
You have to have a safe space to fail. And depending on your organization, it may need to be in a really protected lab environment, and it may need to be something that's more of an incubator of a clinic that is ready to try something, and they'll let you know quickly, and they're okay with their day getting derailed by a process that didn't work. It's kind of like when you have to write an important speech and you write it all out and you think it sounds great, and then you go to read it out loud and all of a sudden you realize your phrasing's completely off. You just need that space to test out your phrasing and see if it's going to work in the way that you're going to be using it.
So I guess you got to be very flexible. You have to be willing to pivot. I thought it was going to do X. It's not working out that way. And I need to look at the data on the ground.
Yeah. And it's all back to that experiment of what is your hypothesis and what data do you have to support that. When it comes to how that works with the EHRs and all of the vendors coming through, we're in a weird time with AI as fast as everything's moving, but in a beautiful time and in a space where we have more data than we know what to do with. And is there a way to use that for good? And it always will have some sort of interaction with the EHR because that is where the data is held on the individual patients. But whether we're using that to solve the problems for that organization, it might be from the EHR, but it might need to be from a vendor because it needs something more sophisticated and process heavy than specifically in the nuts and bolts of the EHR.
Excellent point. Kayla, I want to rope you in here. good ideas often break between departments. I'm assuming that we have lots of chefs in the kitchen. IT wants control, clinical wants speed, finance wants proof. How do you keep everybody aligned so the projects don't get stuck? I'm assuming that's a real problem.
Yeah, and I think that's a real role for innovation and this innovation lab we were just discussing, right? The ability to keep multiple teams headed in the same direction and working towards that North Star, right? Grounding everyone in that problem, I think, is so central to how a really great innovation department is run, right? Having that connectivity into the organization. I've seen innovation departments that really operate pretty separately, and that doesn't tend to work well, especially when it comes to scaling technology, because you must be really connected in with those leaders in the departments that you referenced, right? Everything from IT to finance. And so having those relationships at the end of the day, healthcare is incredibly relational, as we all know. And so having those tight relationships where when problems arise, because they will, they always do. You can go to the greatest of technologies, and when you launch it, there's always going to be challenges along the way. So having those relationships and that trust and that really core team partnered together with the North Star, I think really helps to work through those challenges. From demo to reality, it's always different, right? Every technology looks different when it's in your environment with your processes. And you've got to work through that. That's the change management element that's so critical.
Well, it's kind of, I could be wrong, but in a large health system, there are a lot of problems you're trying to solve across the board. So when you get a new idea that gains traction, how do you decide which ones move forward, what pauses, what stops? Camille, why don't you give us some insight here?
Yeah. At the end of the day, there's going to have to be somebody that's going to make some tough calls. And I think that each organization needs that executive leadership that has a direction they want to see this company go in and what supports that. And you kind of have to be merciless in assessing which pieces are going to help which parts of that vision and strategy. There's so much you could do. Where are we going to apply our efforts is a huge decision. And I'm glad I don't have to make those. I will execute on decisions down the way. But I also think it takes an executive leadership team that's listening because the problems are coming from the front lines, and being relentless in those problems is going to help shape that prioritization and advocacy for each of those departments that may have competing needs, and depending on the environment, depending on the day, depending on where you are, those priorities may shift a little bit, but it helps to really have a good vision of what you're trying to accomplish and then try to get everything to line up behind that.
I think the health systems that are able to move the quickest and really do the best innovation, similar to Baylor, Scott and White, having that clear vision and that true north. I've been fortunate at WellSpan that we have a very clear strategy and mandate and leadership culture at the top that really transcends across the organization, where we have really key, clear initiatives, right? One of ours is we want to get rid of 400,000 administrative wasted hours this year. How are we going to do that, right? That is the true north. Then all of our agentic AI and other solutions start to prioritized against. And so having those really clear mandates and strategies and that culture element that can transcend and get the right folks engaged, I think helps with the prioritization tremendously compared to organizations that want to do everything.
I love the specificity of that. Yeah, it's not, we're going to make admin easier. We're going to specifically attack 400,000 administrative
Is that
hours.
reality, though? Do we always have clear missions, or are they squishy, they overlap, and it depends who the last person that got to talk to the CEO or the chief technology officer?
I think it depends on the organization. And I would say like traditional health system scorecards and things that they have put in place, like are typically clinical, financial, like OKRs or KPIs that they're trying to move towards. So this conversation now around AI and like, how do we get the value out of the AI? And what Caitlin just said is exactly the types of conversations they should be having. Is like, we have a target now to, you know, whether it's an FTE target, an augmentation target, a productivity target, they have to put high level, big bucket targets. And then what is the roadmap of all the different things that you're going to implement and how you're going to incrementally lead to hitting that goal, and an extreme amount of discipline in reviewing and evaluating the performance of all of those different tactics that you put into place. And that is going to vary, I think, from at different institutions. But what you're describing, Caitlin, is like very like, that's like a really great way of framing it and approaching it, and then trying to kind of put your money where your mouth is in execution and making it happen.
And it pushes you to prioritize with the right partners. You brought up a really great point around partnership. And the reason that I think a lot of these pilots haven't scaled is because you need true partners. And so I think the more that we get away from point solutions to more of these platform partners, folks that we can go deep and broad with, I think that's what a lot of health systems are looking to do with the right partners. And you can have those partners helping you achieve those goals, right? We're looking at our key partners to say, how are you helping us achieve this goal? What are you going to do for us? That's what we're working towards. So I think it's a really great true north to keep everyone aligned and having the discipline to prioritize.
Awesome. We're almost out of time, but we do have one last challenge. I do hear a cute dog in the background. I always find it helpful when I ask one of you to ask your peers a question. So I actually asked Evie to come up with a bold question to ask both you, Camille, and Caitlin. Evie, what would you like to ask your peers and buddies here?
Okay, well, so I'm now on the health tech company side, but I used to be on the health system side. So like, I know the experience of going to conferences and getting like mobbed by vendors and like all these different startups that are coming there. I've seen 95% of the time, it's not something that we're typically interested in at a health system. But every once in a while, you come across these gems or these ideas or these concepts. Or what is the best advice that you would give? Because as you know, what's the best advice you would give to a founder, a CEO of a health tech company that's trying to get into your health system on how to approach a partnership opportunity or how to approach pitching one of you?
It's definitely full circle for all the things we've talked about. I think you have to know your audience and you have to know your strengths and how you're going to marry those up. So if you have an organization that has that specificity in its vision, what a beautiful thing for a vendor to know exactly how they can frame up what they do best and how that is going to affect that strategy. There's a lot of general pitches and that sort of thing out there. And it's important to know what your product or what you do as a vendor, but what you could do for me. I mean, Caitlin said the same thing. That's what's going to perk my ears up and keep me interested because I'm working to solve this thing. How are you going to help me do it?
Yeah, completely agree. I think I echo those sentiments. I think not copying, pasting, giving me very specific, like you understand. Nothing gets under my skin more that I finally give a new vendor a chance. And then I get on the call in the first 10 minutes. So tell me about your problems. No. So I think just knowing the organization, especially with ChatGPT and other tools, it's not that hard to understand an organization, where you're at, where you're headed, leverage that. I think also something that's very, specific to WellSpan, but also really to what I look for is co-development, right? Most, especially solutions, are not ready off the shelf. And so the willingness and the understanding by the vendor that we're going to have to do some tweaking, we're going to work together. But we're willing to lean in and we're willing to incentivize you as the health system to help us get this product ready for scale is something that I think is really an appetizing thing for me to see from a vendor.
Well, you guys are awesome. I really want to thank all you guys, Evie, Camille, and Kay. Your insights and experience are bar none the best I've ever heard. But before we wrap up, I want to take 3 takeaways for health leaders working on making innovation last. First, treat every project, that's how I said project in a pilot, like a real decision. If it works, keep going. If it doesn't, stop. Their choices save time and trust. A second point is bring clinicians in early. Ask them what gets in their way and what helps them care for patients. So when help can shape the solution, I think it tends to stick more easily. And third, build momentum step by step. Start small, prove it works. One team, one service line, one system. Thank you for listening today on Beyond the Blueprint. My name is Greg Malcary, and I look forward to seeing you guys next time. Thank you.
Thank you.
Thank you.
Thank you for listening to Beyond the Blueprint. Together, we're exploring how thoughtful design can simplify complexity, enhance patient care, and create meaningful change. If you found value in today's episode, make sure to subscribe and leave a review in order to help us continue the conversation. Let's reimagine healthcare together on Beyond the Blueprint.